Hey, good morning, everyone. How's it going? Good morning. I think we were getting into our drugs, but if I'm on the wrong slide, you can remind me. Yup. All right, it's a good response. Take it. I'm gonna start here in just a minute. It's good morning. Strange, I haven't done like a video in a week. All my other classes have ended, so you guys are the only ones still going. Might be a little rusty on the old streaming. Oh. Well, good morning. I got the recording going here. So just a reminder, we have today and then we have next week off. I don't want you guys to have to be here for Black Friday. That would be a little rude. And then we'll meet the week after, so that'll be on the 4th. And then that's our last class session before the test, which will be that following week. So just an FYI. So we got plenty of stuff to cover, so let's go ahead and hit it. If you recall, last time we were talking about our antineoplastic drugs. We're at least talking about the principles of their use. Let's talk a little bit about the actual drugs themselves. And so this is another good slide that kind of walks you through the different places in which the drugs are working themselves. So if you want more of a graphical sort of representation of where the drugs are working, this is a good slide to go back to. So I would suggest checking that out for studying purposes. You can kind of see where in the sort of whole cell cycle, not the cell cycle itself, but specifically which portion of the cell that the different drugs are working at. So first ones I want to get into are going to be the antimetabolites. And so these are going to be basically drugs that sort of look a lot like nucleotides, or they do something that's trying to affect nucleotides in the cancerous cells to prevent those cells from being able to produce new DNA and RNA. And if you recall, a lot of those cancer cells can't trigger apoptosis because they lose a lot of those cell signaling pathways that induce that. So they just kind of keep replicating sort of ad infinitum, right? But if we can cause enough damage to the DNA to where the cell says, whoa, there's too much damage here, there's no way to salvage, just let's go ahead and scrap the whole cell. That's still a means of allowing for the cell to stop replication. Your own immune system can come in and kind of help get rid of it. And that's will be sufficient in some cases. So looking at this, you're going to see, again, a lot of the sort of classic sort of backbone sort of antineoplastic drugs we're going to talk about. They can't tell the difference between healthy cells and cancer cells, right? And so with also the benefit here is with these drugs is that our cells can't tell the difference between these drugs and normal nucleotides. So they kind of will incorporate both into the DNA. And so basically, by disrupting the production of DNA and RNA, as I mentioned, you're going to cause a lot of damage. You're going to prevent mitosis from occurring, all of that. And that's going to lead to eventual cell death. So, and again, as I mentioned, they're not really going to be selective for the cancer cells, so they will be affecting rapidly dividing healthy cells as well. And so what cells are those? Well, you want to think about things like your GI cells, so all of that, all the cells making up the mucous membrane, all the epithelia is going to be affected. You're going to find that the hair is going to be affected. nails can be affected to some degree. So those are going to be in the immune system, obviously. So like your white cells are going to be affected quite significantly here, which can also lead downstream to things like thrombocytopenia and anemias and things like that. But the immunosuppression is really the big thing that we're really concerned with. So anyway, so three groups you can break these up into include our pyrimidine analogs, purine analogs, and then our folate antagonist. So the pyrimidine analogs, and if you want to think about an analog of these to other drugs we've seen before, if you think back to our antiviral drugs like acyclovir and valacyclovir, these actually work very similar to that. Similar mechanism, but they're selective for human cells as opposed to viral cells. So the first one here is going to be cytarabine. This is frequently called Ara-C. That's not a brand name, that's just an abbreviation. A lot of oncologic people will use Cytosar as the brand name. And so this is a cytidine analog, and you can kind of see how similar these look if you look at cytidine versus deoxycytidine, which is normally gets ready to be involved into the DNA. And then here's what Ara-C actually looks like. So really just moving this hydroxyl group into a different conformation right there. So instead of pointing down, it's pointing up. That's enough to really disrupt that cell from being able to produce new DNA. It basically acts as what we call a chain terminator, where basically it'll get incorporated into the DNA and then the cell can't add anything else onto the end of that. It basically is sort of a dead end for the DNA. And so because of that, we call that chain terminator. So it terminates the chain, and then the cell eventually will say, well, there's too much damage here. Let's just go ahead and get rid of this cell. So that triggers apoptosis happening there. Now, again, I'm not going to ask you routes or specific cancer indications for these drugs. I just use it in order to help provide context for the drugs, just so you can kind of see how we use them clinically. And we use this all the time. In general with like pediatrics, I don't deal with a lot of adult cancer because I work in pediatrics primarily. I deal with this all the time in leukemias in kids. I mean, that's just a very common type of cancer in that patient population. And so we use things like cytarabine all the time. And so, you can sometimes give these drugs intravenously. That's pretty common. And then even intrathecally in some cases. Recall that, the blood-brain barrier is typically trying to keep a lot of substances out of the CNS. And so we can actually bypass that by giving it intrathecally. And that actually provides us an ability to get those cancer cells that are in that kind of protected site there a little bit. So toxicities are going to be really important for these drugs, for all the drugs we're going to talk about today, and so you want to keep an eye on that. Some of these are going to be pretty ubiquitous amongst all of the drugs we'll talk about, so things like myelosuppression, right? Things like nausea, vomiting, mucositis, pretty common. There may be some that are more significant than others, so you would want to note that. But if I ask you on a test which one of these cause nausea, vomiting, diarrhea, well, they're all going to cause that, right? However, there are some things you want to note that may be unique amongst the various drugs here. So, for instance, things like the cerebellar syndrome that can develop with larger doses that are administered. So, if your patient who's getting Ara-C started to develop, dysarthria, which sometimes I feel like I have when I'm trying to teach, or nystagmus and ataxia, that could be seen as a result of using a large dose of cytarabine, or if they have maybe renal dysfunction and they can't clear the drug, for instance, right? Other things you can see here include things like keratitis and conjunctivitis. So frequently they'll complain of like dry eyes or eye pain, and so you may need to use things like steroid eye drops or saline eye drop replacements, artificial tears and things like that in order to prevent, corneal abrasions and whatnot. Now, similar to cytarabine is going to be another one called gemcitabine. You can see here this is the same sort of mechanism, but instead of moving that hydroxyl group, we just go ahead and put 2 fluorides on here. And again, the cells just don't know what to do with that once it gets incorporated into the DNA, so it can't elongate any further onto that. So again, acting as a chain terminator. Again, similar toxicities to what we saw before, so that myelosuppression, seeing GI effects like things like the mucositis, things like malabsorption of food and nutrients and things like that. Frequently when I talk about things that are count dependent, that means that you have to make sure that patients white count has recovered, their neutrophil count has recovered, they have enough platelets around in order to prevent bleeding. So those are things we're definitely watching for, because again, the white cells and all of your bloodline is going to be pretty significantly affected by these drugs here. This one in particular can cause some flu-like symptoms, so things like myalgias, arthralgias, low-grade fever. So frequently we'll pre-treat with things like acetaminophen in order to mitigate that. Another one here, it's called 5-fluorouracil or 5-FU. So again, if you ever don't like a patient, you can say, hey, 5-FU, buddy. I'm just kidding. Don't do that. And then another one called capecitabine, which is actually an oral form that gets converted over into 5-FU. So this works a little bit differently here. Instead of working to get incorporated into the DNA like something like gemcitabine or cytarabine did, this actually ends up inhibiting the enzyme thymidylate synthase. So instead of preventing further elongation of the DNA by getting incorporated into it, this actually prevents the enzyme from producing new nucleotides. So for instance, you can't produce thymidine if this enzyme here is being inhibited. So this is one way to stop this cycle here of producing new nucleotides. The cell can't produce new nucleotides, then it can't produce any new DNA, it can't undergo mitosis and all of that. Again, another pretty common one you'll see in lots of different types of leukemias. Similar side effects to what we saw with like cytarabine. So, GI effects, blood cell effects, cerebellar syndrome, like I mentioned before there. And then sometimes what you'll find with these drugs too, and this will come up a few times, are this peripheral neuropathy that can develop, and it tends to preferentially affect some of the longest nerves in your body, and so those are usually things that go to the distal limbs. So if you think about like the fingers and toes and things like that, that's something we call either like a hand-foot syndrome, where they develop a peripheral neuropathy. They can develop paresthesias and things like that, or you may hear call it a stocking glove distribution. That's basically the same thing. So either hand-foot syndrome or stocking glove neuropathy. You'll hear it called that. So pretty similar effects here amongst the pyrimidine analogs. So then to switch gears a little bit, you have the purine analogs. And again, these are going to work just the same as the pyrimidine analogs, things like the cytarabine we looked at. Here we have 6-mercaptopurine and then thioguanine, very similar mechanism. It's just instead of trying to look like a pyrimidine, it looks like a purine instead here, and does the same exact mechanism of preventing DNA elongation. So it again acts as a chain terminator in those cases there. This is one, and actually you'll see 6-mercaptopurine on your prescription assignments. That should look familiar to you if you've looked at that. This is another one we can actually see that hepatotoxicity is one we're going to be looking for with this one, where we want to make sure that we're looking at LFTs both at baseline and then a follow-up, and you'll see that's pretty common to be monitoring that for a lot of these drugs here for these patients. And again, here's a case where pharmacogenomics actually come into play here, where you can actually find that some patients may have mutations and may have polymorphisms that lead them to changes in certain enzyme expressions to where they may actually not be able to clear the drug as well. And they can have even worse toxicity than someone who does not have that polymorphism. So in some cases, you may do preemptive checks on these patients. You may go ahead and get their genotype for that mutation and see, hey, do they have this enzyme in good supply or not? And then it may lead you to choose this drug or not in some cases there. So it's kind of interesting way that we use pharmacogenomics to try to, be a little more selective on what drugs are kind of best for our patients. All right, and then the third category here of antimetabolites is the folate antagonist, and so this is going to be methotrexate, and this is a big one we're going to see come up pretty commonly because it's not just used for cancer, but also for a lot of rheumatologic conditions, and so we might actually see it come up in the GI section a little bit later on. And so this is basically working. If you want to think about an analog to methotrexate, you want to think about something like sulfamethoxazole and trimethoprim. If you recall, Bactrim worked to prevent folate utilization within the bacterial cells. This does the same thing, but for human cells, essentially. And so if you were looking at this enzyme cycle here where thymidylate synthase is working to produce new nucleotides, a lot of this process is contingent upon the recycling of folic acid. Folic acid we take into the body, gets converted over into dihydrofolate, and then that gets converted into tetrahydrofolate. This step here is done via an enzyme called dihydrofolate reductase, and methotrexate is what stops that. So again, if you want to know the mechanism of methotrexate, say that it stops dihydrofolate reductase from utilizing folic acid, and that prevents new nucleotide formation and new DNA production. That's enough for my purposes there, okay? So by doing that, again, that eventually leads to cell death. So this can be good for a lot of things, both cancer, because it will get rid of a lot of your white cells. It'll definitely help to decrease the number of those because they can't replicate as quickly. But it can also help for a lot of rheumatologic conditions where the body is sort of having an inappropriate immune response, right? So if you want to tamp down that immune response to say for instance, well, like rheumatoid arthritis. So if you want to decrease the immune response to your joints, causing joint destruction, methotrexate can do the same thing, right? Now, if you're comparing dosing between cancer versus like a rheumatologic condition, cancer is going to be a lot bigger dose because you're trying to get rid of all of those cancer cells versus something like rheumatoid arthritis or Crohn's disease or something like that. It's just you're trying to kind of tamp down the immune system. You're not trying to get rid of it completely. So again, if you're thinking about things like secondary infections, it's probably more likely to occur for someone with cancer versus receiving methotrexate than someone who had RA or something like that. So this is another one that has a pretty wide range of means to give it: orally, IV, intrathecally. We use methotrexate quite frequently, all the time. So toxicity is going to be important here. So we see a lot of myelosuppression, GI toxicity. This is another one called with significant hepatotoxicity. So you definitely have to watch for liver function tests for sure. Make sure patients aren't drinking with this because obviously that could exacerbate that. The new thing here is actually going to be renal toxicity. So this is a big one. Methotrexate, especially if you have someone who maybe is like dehydrated or if they have renal dysfunction or something like that, if the concentration of methotrexate in the renal tubules gets too high, it has a tendency to precipitate out, which can actually cause these crystals to form within the renal tubules, which punctures the cells and can cause interstitial damage. So hydration is really important. We want to make sure that the methotrexate does not precipitate out. How we deal with that is by making sure patients are well hydrated, and then we can also give them sodium bicarbonate. This is actually helps to increase the pH of the urine, and by doing that, it increases the solubility of the methotrexate. So that way, the patients, especially when they're getting like really big doses, like grams and grams of the stuff, they can go ahead and just process it through the kidneys without it worrying about causing that interstitial damage. Will just kind of go straight through, and so sodium bicarb really helps out with that. And again, another thing I'll point out here is if there are antidotes to these drugs here, you want to make sure you note those because they're very important to help mitigating a lot of toxicity we see with these drugs. And again, I went into toxicology because I like to fix overdoses and fix poisons in people. Basically we're having to poison these people on purpose to get rid of these cancer cells. So again, I like to focus on the antidotes because that helps to mitigate some of those toxicities. So that's an important thing there. You also want to watch out for like protein binding interactions with methotrexate because other drugs could come and kick it off of albumin. So that could lead to further methotrexate toxicity, or you could see the other way around, and methotrexate can displace other drugs off of albumin, and that can cause issues like warfarin or something like that could be affected. So other antidotes we'll see here, frequently you'll hear what we call like a leucovorin rescue, and that's where basically we give the drug folinic acid. Now, if you look back on the slide here, you notice that the cells cannot utilize folic acid because this dihydrofolate reductase is inhibited. So instead, what we can do is give the activated form of folic acid called folinic acid. That's an important distinction there, folinic acid instead of folic acid. Another name for this is leucovorin. And we will then give that after a patient receives methotrexate in order to try and bypass that block in order to help healthy cells sort of recover. And so you may think, well, won't some of the cancer cells use that folinic acid too? Yeah, they will. But the idea is you're trying to select out and try to help survive or help as many healthy cells survive as possible while trying to get rid of as many cancer cells. So it's kind of a double-edged sword. But again, if you kill off your patient, yeah, you'll kill the cancer, but then your patient's dead, which is no good. So we like to help recover those healthy cells as best we can. We mentioned the sodium bicarb, and then there's a actual enzyme we can give called glucarpidase or voraxase, and this is something that is extremely expensive. We try never to give this if we don't need to, but let's say you gave a very large dose of methotrexate to a patient, all of a sudden the renal function tanks and they can't clear it anymore. That's going to lead to some significant myelosuppression, significant toxicity to the patient, and so that's where we can end up utilizing this drug here, and it will actually work to directly cleave the methotrexate to directly break it down, and then they can just pee out the inactive metabolites. Don't use this too often because it is quite expensive. I think for a single dose of it, last time we had to give it, it's something like $40,000 for just one dose. So it's very, very expensive. You know, so there's certain criteria we'll use before we actually administer it. But next time you hop in your car, just think about that, you know, a dose of that, a single dose of that drug might be more than what your car is worth, or at least a significant chunk of that. So pretty wild how much drugs can cost. All right. So then switching from DNA production side of things, let's go to the actual mitosis side of things. And so this is where we're going to have drugs that will target the microtubules. And if you go back to maybe your undergrad biology book and you go through mitosis, you'll see there's the PMAT, right? It's prophase, metaphase, anaphase, telophase, right? Towards the end there, that telophase, that's where you're actually pulling the chromosomes apart, so that way the cell can then divide and now you have two new cells, right? Well, if you help to inhibit those microtubules, then that can disrupt that final phase of mitosis, and then it prevents the cells from actually dividing. And so that's one way we can try to target some of these cancerous cells. We have two groups here. We have the taxines and then the Vinca alkaloids that we're going to be looking at here. So first one are the taxines. I always like to point out if things come from animal or plant sources, because I think that's interesting that we have these kind of medicinal products just out there in nature. And so again, you always say, well, it's all natural, man. It's got to be good for you. Well, no, this is actually will kill your cells too, but it may treat your cancer if you have it. But this is a Pacific yew tree. So if you ever see plants that look like this, maybe if you travel out towards the West Coast or something like that, you might see trees like this. Do not eat these trees. They might actually give you pretty significant toxicity. So just in case you need that warning. But the taxines have two drugs in this category here called paclitaxel and docetaxel. And so these basically work to promote microtubule formation, but then they prevent the breakdown. And so that's an important piece there. You want to form the microtubules in order to finish up mitosis, but you have to be able to break them down in order for the whole process to finish. And this prevents that. So that's one way we can try to help kind of stall mitosis from occurring and preventing those cells from replicating. Of course, both of these can cause myelosuppression. Docetaxel is unique in that it causes fluid retention, so this might be bad for patients with, say, significant liver dysfunction, have ascites, or if they have CHF or something like that, so we want to be careful there. And then paclitaxel can cause significant neurotoxicity, so a lot of peripheral neuropathies like the hand-foot syndrome we talked about. And then this one is pretty likely to cause hypersensitivity, so allergic reactions there. So a lot of times what we're going to do before patients will get this is we do pre-treatment. And again, when you look at patients getting cancer drugs, oftentimes they're getting a lot more drugs than just the chemotherapy, because those are all the adjuvant drugs we have to give along with it. So things like steroids and whatnot. And so this is where we do that pre-treatment. And so things like prednisone or methylprednisolone or something like that is frequently given beforehand, because that helps to limit a lot of the side effects like the hypersensitivity, flu-like symptoms, and things like that. So if you see that, there's going to be a couple of reasons why we give corticosteroids, some of which I'll talk about a little bit later, but this is one of them. And then on the other side of things, instead of preventing the breakdown of the microtubules, if we wanted to prevent the formation of microtubules, we could use something called the Vinca alkaloids. And so if you're not an amateur botanist, this is actually a picture of the periwinkle. And this is where we get the Vinca alkaloids from, or at least originally. Now we have synthetic means of producing them, but this is where we first sort of found them, the periwinkle. And so we have three drugs in this category. We have vincristine, vinblastine, and vinorelbine. And as I mentioned, these are going to basically prevent the microtubules from forming in the first place, so they can't prevent or can't finish mitosis essentially. And so here you're going to find that in terms of toxicities, certainly we're going to see that neurotoxicity is going to be a big concern with these for sure. You want to make sure that you're, assessing for that, making sure you're checking, function of the nerve endings there by checking for sensation and things like that over time, because these can develop over time. This is also another set of drugs where we do not want to give these intrathecally. This is actually considered to be fatal if you do this, so a big no-no. And you think, like, well, how would I ever accidentally give a drug intrathecally? That sounds pretty difficult, because I have to get a lumbar puncture all set up and everything. Well, oftentimes patients may be getting something like vincristine IV. Meanwhile, they're getting methotrexate intrathecally at the same time. And so if you were to then mix those up, for instance, give one the other route, then that's where they can cause this sort of fatal reaction there. So there's a lot of safety procedures we put into place to make sure that does not happen. But again, just something you want to keep in mind, a good, board style question you should know for that. So other things to watch out for here, vincristine itself, with that neurotoxicity, not only do you get the hand-foot syndrome, but you can also end up actually developing some paralytic ileus and constipation. We have one patient who had to actually stop taking vincristine for part of his cancer regimen because of the fact that his constipation was so severe that he was having to actually be admitted for that. He couldn't pass any stools, was having severe abdominal pain, so it could be pretty significant there. Another thing here are the idea that the Vinca alkaloids are strong vesicants, and you're going to see this pop up a few times, and you say, what's a vesicant? Well, basically, it's something that causes tissue destruction, can cause a significant tissue injury, especially of the subcutaneous tissue and things like that. So here's what happens. Imagine you have a situation where a nurse maybe starts an IV line in a patient in order to infuse their vincristine, but unbeknownst to her, she accidentally blew the vein. She thought she had a good return, but she actually didn't. And now when you infuse that vincristine, it's going into the subcu tissue instead of going into that vein. That's where you're going to get a lot of pain. You're going to start to get a lot of tissue destruction, and it can, in some cases, has led to amputations before. But it's not a great sign there. So that's one of the things we really want to be careful of. If you have something that's a strong vesicant, you have to make sure you're either giving it through a central line, or if you're giving it through a peripheral line, make sure that it is very well secured. Make sure you have good flow through it. Otherwise, you can run into this issue here where you can cause significant injury. Every place you work at will have something called a extravasation protocol. And so if a drug is accidentally infused outside of the vein into the surrounding tissue, it's called extravasation. So extravasation kind of makes sense when you think about it with the different constituent parts there. So that is something we would like to avoid at all costs, because again, you don't want to cause significant damage on top of trying to treat their cancer. Next up, we have drugs that are going to, what we call topoisomerase inhibitors, and these are going to be sort of similar to the fluoroquinolones in terms of their actions on bacteria. And so we have two main versions of topoisomerase. We have topoisomerase 1, which is responsible for causing single strand breaks, and topoisomerase 2, which does double strand breaks. And if you recall, topoisomerase, or DNA gyrase is another name, is responsible for helping to allow for unwinding of the DNA, so that way it can allow for DNA replication to occur. DNA polymerase can come along and do its thing. So this is an important thing here, because if we inhibit this process, it's going to cause more and more strand breaks to occur, which eventually leads to enough DNA damage to lead to apoptosis. So a very handy set of drugs here. I'm not really going to care if if a drug inhibits topoisomerase 1 or 2, but you should at least know at a baseline that its main action is to inhibit topoisomerase. That's good enough for me. We're going to have 3 drugs in this category here. We have the epidophylotoxins, which is a fun word to say, with the anthracyclines, and then the camptothecans. So the epidophylotoxins, this is a lesser known plant. This is called the May apple. So again, another plant source for some of our drugs here. And 2 drugs fit into this category called a toposide and then tenipicide. And again, these are going to be basically inhibiting topoisomerase 2 and causing more and more DNA strand breaks, right? It also can affect the microtubules, but this is sort of a minor mechanism as compared to the one that I bolded here. So just know that it inhibits topoisomerase, and that's good enough for me. Again, a lot of dose-limiting myelosuppression. So that means you have to check CBCs before they can get another dose, make sure that they've recovered enough. Otherwise, too much myelosuppression leads to too much of a risk of infection and potential death. A lot of nausea, vomiting seen with this one, and then alopecia can be another common side effect. Next up is the anthracyclines. So 3 in this category of doxorubicin, daunorubicin, and the mitoxantrone. If you ever see a patient with like a red IV bag hanging, chances are something like this. If you can kind of see the color here, it's quite red, which is interesting because it can actually turn a lot of the colors of the patient's secretions to red as well, the urine, sweat, things like that. So pretty interesting side effect there. So these will inhibit topoisomerase 2, and they also have this neat kind of function here where they do DNA intercalation, which again is a fun word to say. If you look here, you can kind of see the kind of planar structure of the drug. It's able to kind of insert itself into the DNA to cause disruption here, so causing actual physical disruption of the DNA that leads to further damage and eventual cell death. So that's one thing there. And then also it can lead to what we call free radical production. And basically that just means that it's forming these reactive oxygen species that can go around and cause oxidative damage to the cell. It's like proteins, DNA, all kinds of things. So just another means for it to kind of wreak havoc within the cancer cell to eventually kill it off. So obviously myelosuppression is going to be a risk here. This is a unique one with the anthracyclines, where we have cardiomyopathy and CHF can develop here. Basically, the heart is not able to really detoxify those free radicals all that too effectively, and so it leads to having more disproportionate damage done to the heart than other tissues in the body here. So, and actually for these patients, there's going to be a lifetime max dose that they can receive. And once they hit that lifetime max dose, they can never receive an anthracycline again. That's just kind of it for them. So it's kind of interesting, kind of unique thing you'll see with these set of drugs here. And certainly you're definitely checking their echo. So get a baseline echo and then you'll follow it up at regular intervals to make sure that they're not having any significant, injury too early, and you can stop the drug early if you need to. And in terms of antidotes, one way we can try to get around that's by giving the drug dexrazoxane or Zenocard. And so this actually works as a chelator that will chelate iron, and that actually helps to prevent the free radical generation. So we will give this along with something like doxorubicin as a cardioprotective agent there. Okay. This is another really strong vesicant, just like the Vinca alkaloid. So you'll want to be really careful here if you have a patient who has tenuous IV access, or just make sure they have like a central line or something like that to prevent any sort of extravasation from happening here. And again, the red discoloration of urine, sweat, etc. can be kind of concerning to the patient, so let them know that is a pretty normal side effect you'll see with that drug. Then we have the camptothecans, so Topotecan and then irinotecan. These are, again, working on Topoisomerase 1 primarily. And so with these ones, you're going to see these can be pretty significant in terms of myelosuppression, so you want to be careful there. And then, interestingly enough, diarrhea is going to be another big side effect you're going to see with these drugs here. And this is mainly due to the fact that it inhibits the enzyme cholinesterase. And so by inhibiting cholinesterase, you're going to find that that will decrease the metabolism of acetylcholine. You're going to have more acetylcholine around. That's going to be affecting your muscarinic receptors, and that's why you see a lot of that diarrhea associated with that. So that can be pretty significant, pretty unique to more so irinotecan, but can also happen with Topotecan as well. Okay, so then getting into sort of the last category of our kind of standard, sort of like, old school sort of, chemotherapeutic drugs here with the alkylating agents. There's going to be a lot in this category here we're going to talk about. And so most of the other drugs we're talking about tend to be more on the cell cycle specific side of things. So for instance, like, if you're not producing new DNA, then cytarabine is not going to be all that effective. As opposed to the alkylating agents, these cause direct damage to the DNA itself by causing covalent bonds to be formed there. And I'll show you pictures of what that looks like in just a moment. The genesis of these drugs is actually quite interesting. If you all go all the way back to World War I, if you've ever heard of mustard gas before, this is actually the origin of some of the alkylating agents that we have now. And so this was actually discovered back in the 1940s. They saw that soldiers who had been exposed to mustard gas actually had pretty significant leukopenia develop, because these drugs and mustard gas was acting very similar. Now, the drugs themselves cause vesication to, you can see here, strong vesicant, so it caused significant damage to the skin, the mucous membranes, and all of that. And so, you'll see similar activities of these drugs in the body as well. So, again, using something very dangerous and trying to use it to, target these more cancerous cells. So anyway, what we're going to see here is that it will covalently bind to alkyl groups and proteins and DNA and whatnot, and that can actually lead to things like strand breaks. It can lead to intra-strand binding, and that can cause disruption of the DNA actual structure there. And these tend to be cell cycle non-specific, so these are going to work any time of the day. These are going to be not very selective for cancer cells as well, which means they're affecting your healthy cells as well. So these have very nasty side effect profile. Right, much nastier than a lot of other drugs we've looked at so far. Not only that, but they can also be cytotoxic, meaning they directly kill cells. They can also be mutagenic, meaning they can actually induce mutations in the DNA, leading to actually new cancers. So it may sound kind of counterintuitive, but just like we saw with antiarrhythmics, any antiarrhythmic can cause an arrhythmia. A lot of chemotherapy can actually cause cancer, right? So it's something you're going to be looking out for. So they can be carcinogenic. certainly myelosuppressive, so very significant there, and then teratogenic as well. So obviously, pregnant patients with cancer, most of these drugs are not going to be great for developing fetus there. So that's something you hopefully will not have to worry about. But occasionally patients may become pregnant, and that's going to be a complication for sure. Another thing you want to watch for as well is this pulmonary fibrosis. This is going to be pretty ubiquitous amongst the alkylating agents, but there'll be one in particular I'll point out that tends to be a little bit worse from that standpoint. Okay, so first off, we have the nitrogen mustards, and of course, this is not a mustard I'd ever want to put on my hot dog, but user experience may vary. And we have two in this category here called cyclophosphamide and then ifosfamide. And again, you can kind of see how these operate here. So if you have the nitrogen mustard and then you have guanine, it can just basically come along and displace that chlorine. And then here you go. Now you have basically the nitrogen mustard causing an intrastrand or interstrand covalent binding here. And again, if this is causing deformation of that structure, that prevents things like DNA polymerase from coming along, producing new DNA, etc. So this causes really just wreaks havoc on the DNA in the cells here. Although it's kind of interesting, they call them nitrogen mustards. You can notice here, actually smells like garlic, horseradish, so there are some crossovers there, which is kind of interesting. With these two in particular, there's something called acrolein that it forms. This is a toxic metabolite, and this is important because this can actually cause a hemorrhagic cystitis. So obviously, KUA would be important to look at for these patients here. In order to prevent acrolein from causing damage, we will frequently give along with it an antidote called Mesna. Mercaptosulfonate, I think, is like the full name, but we always just call it Mesna. Mesnex is a brand name for that, and it basically binds to and inactivates acrolein. So this is really important to make sure patients are vigorously hydrated and that they receive Mesna when they're getting something like cyclophosphamide to prevent that hemorrhagic cystitis, that side effect there. So we want to prevent that. Other things you can see, and this is more so with ifosfamide, is an encephalopathy. So you do want to kind of monitor for things like, memory impairment or mood changes or just seeing, just mental status changes. So you want to be careful with that. And then certainly you can see renal toxicity, myelosuppression, alopecia, nausea, vomiting are going to be very significant with this whole group of drugs, right? Because again, they're affecting not only the rapidly dividing cells, but they're affecting healthy cells quite significantly. So this is quite common with all of the alkylating agents we're going to see here. Okay, another set here is called the Nitrosoureas. This includes carmustine and lomustine. And again, sometimes you see them abbreviated BCNU and CCNU respectively. Again, if you just know carmustine and lomustine, you're pretty good. And so this is actually pretty good for treating brain cancers because they have pretty good lipophilicity here. And actually, here's a picture, and you can actually find some really neat videos online of this gliadel wafer that they use, where actually a surgeon can go in and actually excise a brain tumor. And again, it's impossible for a surgeon to know, did they get every single cancerous cell when they remove that tumor, right? So what they can do is actually put these wafers that have the drug carmustine impregnated into it and actually allow that to affect the surrounding tissues so that any brain tissue that had cancer cells left over can be affected there. And then you basically just put over the skull flap again and go ahead and just let the drug sit there, and eventually you can go back in and take those wafers back out. So pretty wild of actually direct application of drugs into the brain, like by actually removing the skull, removing part of the brain, actually putting it in there. So it's pretty unique. Now these drugs can also be used in order to prep patients for bone marrow transplants. And so this is important because these drugs cause probably the worst myelosuppression out of any of them. I've already mentioned myelosuppression being a common side effect for all these drugs, but this is even worse because you can see that it can last for up to 2 weeks. And you can also have what we call the nadir. And nadir just basically means the lowest point that those white counts are going to hit, right? Basically, nadir just means the lowest point that something hits before rising back up. And so the nadir may actually be delayed by 4 to 6 weeks. And so that's pretty delayed there. You might see that. And again, once these patients develop this myelosuppression, they can't fight off infection. They're going to get viral infections. They're going to get bacterial infections, fungal infections, mycoplasma. Everything is on the table there. And again, I have seen more patients succumb to infections secondary to chemotherapy than I have their actual cancers themselves. So it's something you really want to be watchful for from that standpoint. Up next are going to be our platinum analogs. These are basically for patients that have like the best insurance. I'm just kidding. This is not really for that. They do include platinum, right? So it's kind of I always think of this as kind of like the bougier of the chemotherapeutic agents here. But we have drugs like cisplatin, carboplatin, and then oxaliplatin. And so their mechanism is basically just like the other ones, to bind to different portions of the DNA to cause both inter-strand breaks, where they're causing it between strands of DNA, and then the intra-strand breaks here, we're actually, or binding, we're actually causing it within the same strand. Regardless, the effect is the same. We're going to be causing disruption of the DNA such that DNA polymerase cannot come along and cause replication to occur there. This is another one that's pretty significant in terms of its toxicity. So significant nephrotoxicity. So you have to hydrate these patients really well. Frequently, they're getting liters and liters of fluid, both before, during, and after they receive a platinum analog, in order to make sure that they can flush that drug through as best as they can. And they can also lead to ototoxicity. You can see peripheral neuropathies can be significant. And this one, of all the drugs that cause significant nausea, vomiting, this is some of the worst ones. And so in a little bit, I'll talk about the emetogenic potential of these drugs, and these tend to be pretty severe from that standpoint. A couple other alkylators we have here include things like dacarbazine and then temozolomide. These actually are going to have the same mechanism here of binding to the DNA. They might just have a few different intermediary steps here, such as getting metabolized to a product called MTIC, which then can methylate guanine. But again, those kind of details, as long as you know they're alkylating the DNA specifically, that's pretty much good for my purposes there. And of course, toxicity, vomiting, alopecia, myelosuppression, pretty common with all of these alkylating agents there. Now, busulfan is pretty unique because, as I mentioned, all the alkylators can cause pulmonary fibrosis, but this is quite significant in terms of it causing this. So you definitely want to monitor for things like PFTs, both the baseline and the follow-up, because they can develop what they call busulfan lung, and that can actually be fatal in some cases there, so you want to be watchful for that. Okay, so a few miscellaneous agents here to cover. Now, this is going to be something where I can't cover really every single one of them that's out there, because this is kind of an exploding sort of domain of oncology. So especially with the monoclonal antibodies and some of the growth inhibitors that we're going to see, there's just too many to name. They get too specific for their certain types of cancers, and so I'll just highlight a few different ways we can try to tackle cancer via non-traditional sort of methods there. So some of this includes hormonal therapies. So we'll find that, androgens and estrogens can cause growth of cancerous tissue. Think about breast cancer, think about testicular cancer. Those can all be sort of propagated and induced and influenced by things like androgens and estrogens, right? So if we can aim for ways to either decrease concentrations of these hormones or decrease their actions on the cells, then hopefully can prevent further growth of those cancerous cells, right? And so these can be used in conjunction with other traditional chemotherapy. They can be used in conjunction with surgery, things like that, in order to prevent further production of those cancerous cells there, right? Corticosteroids could also be used as well. So utilizing things like prednisone, dexamethasone. We know corticosteroids are immunosuppressive because they actually inhibit the production of white blood cells. And so this does the same thing here for leukemias. Not only that, but it also has the additional benefit of being able to treat chemo-induced nausea, vomiting. So patients who are getting dexamethasone prior to chemotherapy may either be getting it for treatment of that cancer and or treatment for nausea, vomiting related to chemotherapy. So kind of dual benefits you might see from these drugs here. Next, we have what we call the biologic response modifiers. And so these are going to be a set of drugs that affect protein kinases. And so if you recall all the way back to our Intro to Pharm class back in the summer, although I'm sure most of you probably repressed those memories in order to stave off the PTSD, but we do have these protein kinases, and these are really important for causing growth of different types of cells. They kind of induce these different pathways and influence cell differentiation and growth and whatnot. And so you're going to find that we have two main types. We have some of these receptor tyrosine kinases. And so this includes things like insulin receptors, platelet-derived growth factors, epidermal growth factors, all kinds of different things. We can stimulate different types of tissues, some of which may be cancerous. And then we also have a few enzymatic ones that can be more intracellular versus, say, on the cell surface. And if you recall, this is kind of what they do, where basically a signaling molecule will bind to a tyrosine kinase. They will then dimerize, they get phosphorylated, and then from there they can cause whatever cell signal activation that it has to cause. And so here's a picture of one example here, where you can have an epidermal growth factor receptor binding to a ligand, and you can see all the different downstream processes that it causes in order to cause proliferation and cell cycle progression of that cell. So if you imagine the cell is cancerous and you had this ligand coming and binding, that's not great because you're going to get propagation of that cancer. So what would happen if we inhibited this and had a receptor blocker here? And what you're going to find is with certain types of cancers, these cells may be more likely to express certain varieties of these receptors here that maybe healthy cells might not. And so this is actually going to be a means of targeting or more selective in targeting cancer cells versus our healthy cells, because maybe only cancer cells are expressing this. So to give you an example, here we have two. One is a myeloid tyrosine kinase inhibitor, and the other one's an epidermal growth factor inhibitor. And so basically, the first one here we have imatinib or Gleevec is an oral agent that affects specific cancers that have a specific mutation. So for instance, here with chronic myelogenous leukemia, if the patient has this BCR-ABL mutation, then imatinib will be able to treat that. It'll be able to inhibit those particular proteins to prevent cell growth and differentiation. Or if they have this EVT6-PDGFR mutation. Now, do I care that you know the mutations? No. The point being, though, is that by trying to target these very specific proteins, and by trying to that only the cancer cells are expressing, you save all of the healthy cells. So this is a means of being much more targeted in order to help preserve our healthy cells, which all of the ones we saw before, all the classic ones, they don't have that ability, right? So you do want to be, it's nice that we have more targeted therapy nowadays, and that can really change things. But if the patient doesn't, if they have CML and they don't express this mutation, then this drug is no good for them, right? That's why things like getting the flow cytology and actually getting an idea of the different mutations that the cells express is really, really important for those patients there. And if you look at the toxicity profile, a little bit of nausea, vomiting, maybe some edema, much preferable to a lot of the other drugs we already saw, right? Gefitinib is another one that be specific for this epidermal growth factor. It could be used to treat lung cancers. You can see here much better side effect profile as well. Again, biggest thing here is just to note how the mechanism is a little different, how it's going to be specific for targeting certain types of cancer cells while helping to save our healthy cells. Now, there's also going to be a ton of monoclonal antibodies you're going to see out there. And of course, how do you tell if a drug is a monoclonal antibody? Well, it has MAB on the end of the name there, right? And so the first one here we have is called rituximab. This is actually an antibody that we have developed to target CD20 antigens on B lymphocytes. And so you notice here it's actually a chimeric protein, meaning it's a mix between some human protein and then murine protein. If you're not familiar, murine protein means mouse protein. So if you give this to your patient, all of a sudden they have a desire for cheese. That's totally normal. You can just indulge them. I'm just kidding. But anyway, but if you can see how, certain types of cancers may be more likely to express cells that have the CD20 antigen. So for instance, non-Hodgkin's lymphoma would be expressing the CD20 antigen. This would be a good way to target those cells specifically while preventing damage done to other healthy cells, right? And then once this antibody binds to that CD20 antigen, then it's able to basically activate the complement system and very tidily sort of get rid of all of those particularly cancerous cells. And so with these drugs here with monoclonal antibodies, you're going to find that in general, anaphylaxis and allergic reactions are sort of part and parcel with these drugs here. Especially the more murine protein that they contain, the more foreign it looks to the body, and thus the risk for anaphylaxis is higher. Okay. We'll find some later on that are going to be more humanized, meaning that they mostly just contain human protein, and that's going to be less of a concern there. But because this is chimeric, which you can tell because there's an X in the name, it's kind of part of the naming convention, it'll tell you that, yeah, this is likely. So they get a lot of infusion-related reactions. They get fever, arthralgias, chills, things like that. Nausea, vomiting. Should be urticaria. I don't know why I spelled that incorrectly. And then you can see things like urticaria, bronchospasm, and all of that as a result of that. So frequently we end up pre-treating these patients with things like acetaminophen, corticosteroids, Benadryl, or other first-generation antihistamines in order to prevent some of these reactions from happening there. But definitely you're watching for further reactions, and normally I have things like epinephrine on hold just in case something bad does happen. And in terms of toxicity, mild myelosuppression, much less so than you would see if it was like a traditional, alkylating agent or something like that. So and again, that's just a survey of some of the newer miscellaneous agents there. If you actually go and look at all the new monoclonal bodies that are out there to treat cancer, that list has exploded. But again, each of them are very specific for a certain target, for a specific type of cancer. So me getting into them at this point would be kind of outside of our scope, I think, and it would probably just serve to melt your brains a little bit. So no point in getting it beyond that. I think I'm just kind of giving you the basics that you need in order to be successful for kind of, evaluating and looking at these patients who may be on some of these drugs here. So anyway, so in terms of dosing and administration, many regimens are going to be count dependent. And when I say that, basically means that when you give a lot of these drugs, especially some of the old school ones we've been talking about, they tend to lead to significant myelosuppression. They can affect the platelets and all of that. So we have to give the patient time to recover in order to give the next dose. Because if we keep hammering them, the drugs over and over again, they're going to succumb to either other infections, opportunistic infections, or they'll bleed out, something like that. So that's why I say they're count dependent. They have to recover to a certain platelet count, to a certain absolute neutrophil count, etc. But you're also going to be looking for renal function. You're looking at urinalysis. You're looking at hepatic function, depending on which drug you're giving, which toxicities are a little bit more likely there. And again, you're going to watch for how drugs are being dosed specifically, because you may find some cases more age-based, maybe based on body surface area. This one's probably most common that we'd be dosing based off of that. So you have to get the height and the weight of the patient, and then occasional weight-based dosing. So again, as these things change, especially if you're dealing with like pediatric cancer, for instance, patients are always growing, they're getting bigger, but you may also find that weights change as well, because if they feel so sick that they can't eat well and they're having poor oral intake, maybe their weights are going down, you have to readjust your doses based off of that. So these are all things you want to consider when watching drug dosing for these agents here. Now, the drugs are not just hazardous to the patients, but they can also be hazardous to healthcare workers as well. So proper PPE is really important whenever handling and administering chemotherapy. So making sure that, if you're going to be administering it, so say you're giving methotrexate intrathecally, make sure you have things like gloves, gowns, shoe covers on, because you don't want the drug to get on you, because it can also be mutagenic and carcinogenic to you as well. Especially if you have any risk for aerosolization, that can also be a problem as well. So you want to make sure you have mask and eye protection on. And not only that, but especially like nursing as well, you want to think about patient excreta can actually be considered hazardous. So things like diapers have urine in them, blood, things like that, and a lot of that can be dependent on when the last time they received chemotherapy was and how long it takes to get out of the system can lead to some issues there. So again, make sure you use proper precautions if you work with these patients, just to make sure that you yourself don't get exposed to the medications. Now, in terms of supportive care, other things we can do for these patients is try to help them recover a little bit faster from a hematologic standpoint. And so this is where we can actually give things like colony stimulating factors. So for instance, if they are anemic, well, we can potentially give them erythropoietin to try to stimulate that. Or sometimes we'll give them what we call granulocyte colony stimulating factors that try to help stimulate things like granulocytes, like your neutrophils, to actually form. So these are ways we can try to give this to help them recover a little bit faster from that standpoint. Now, as I mentioned, they're going to be at increased risk for infection, anemia, and bleeding. So you really want to be cautious with them, especially if they are neutropenic and they come in. Frequently we'll have patients with cancer that will show up to the ER with just fever, right? Which you may think, well, why does everyone show up with fever to the ER? These patients really should, because if they're immunosuppressed, they may not be able to manifest a lot of other signs of infection. And so they could have something really serious going on and just have a low-grade fever that's evidence of that. So we call that febrile neutropenia. That's a big deal because we worry about a lot of infections. And so things you want to think about too is that neutropenic patients, you don't want to give any sort of rectal drugs. You don't want to do any rectal temperatures. You don't want to do any sort of digital rectal exams, anything like that. Because think about the rectum, if you're giving chemotherapy and you are damaging all of those rapidly divided GI cells, that tissue becomes very friable. Friable basically means very brittle. It's easy to break. And so not only do you have a lot of bacteria growing in the rectum, if you inserted a thermometer, you could break that tissue. You could cause transposition of bacteria into the systemic circulation, and then they don't have an immune system to really fight that off, right? So that's why you want to be really careful with rectal administration for any neutropenic patients. Also, that's why in a lot of hem-onc units, they don't allow fresh flowers or fruits that don't need to be peeled, because they can also harbor bacteria that can infect your patients. So really important from that standpoint, no no grapes or things like that for them. Maybe something like an orange or a banana might be reasonable because that would be a little bit more protected. And so, as I mentioned, you can give the patient time to recover on their own, but sometimes in some cases, we'll actually give colony stimulating factors that can replace this or help to stimulate new growth, or we can just give replacements. If you have to give platelets, if you have to give, FFP or something like that, that is done occasionally. Other supportive care things, we know GI effects are quite common with these drugs here. You'll see that nausea vomiting is one of the most common side effects you're going to run into. We'll discuss antiemetics more specifically in GI coming up in just a little bit. And so other things to consider too is going to be like mucositis, causing, destruction of some of those oral cells there. Very painful, may prevent the patient from being able to eat and drink effectively. So this may cause them to get dehydrated, which we know affects some drugs. Their weight may not be going steady or going up, and so that can be a problem. You can see that if you're not getting good nutrition, you can't really produce new blood cells effectively. So that's all really important there. Lead to further infection. And then you want to make sure good oral hygiene's in place. Make sure you don't have any, again, transposition of bacteria in the mouth. So things like salt rinses or an antiseptic like chlorhexidine can be used with good effect. All right, so here's a list of amenogenic drugs, and so you don't need to memorize this, but I just want to give you an example of kind of what we're looking at, and just to think of how common it is for these patients to develop nausea, vomiting. You have some drugs are in the really high risk category, so greater than 90% frequency without antiemetics. So it means that if they didn't get anything, chances are they're going to be vomiting, right? And so things like cyclophosphamide, really high dose here. We saw the my platinum drugs here. Where are they at? Have lost them, but things like dacarbazine, things like doxorubicin, all these tend to be pretty. Your cisplatin here, that's what I was mentioning, being a high emetogenic drug. So this is why the antiemetic regimens are so important to prevent them from having a lot of nausea and vomiting, because no one wants to throw up when they get their chemo. So that's it for this section. Let me know if you have any questions while I get the next one set up here. Again, a brief overview, not everything to know about cancer ever, but at least gives you a quick survey and gives you an idea of kind of things you're going to see most commonly, because you may not be the ones to actually be prescribing a lot of these chemotherapeutic agents here, but you may find patients who are on them, and so you want to know what those drugs do. You want to make sure that if you're prescribing a new drug, what that's going to do to affect those patients as well, right? All right, well, doesn't seem like there's any questions, so I will move on to the next section. We're talking about GI here. So let's start with GERD. So what is GERD? Basically, it's where we're going to have this abnormal reflux of gastric contents into the esophagus. I'm sure most people have experienced GERD. If you have the opportunity to have a nice big Thanksgiving dinner next week, perhaps you will experience some GERD symptoms as well. You shouldn't have gone back for that third plate, but you did it anyway, right? Anyway, so why do we have GERD? Well, it's typically due to this retrograde movement of contents from the stomach, right? And again, your stomach is pretty well protected from all of those bile acids and stomach acids you're producing, all of that, to where your stomach can handle it, no problem. The esophagus, not so much. It's pretty sensitive as compared to the stomach. And so when you have contact to stomach acid with that mucosa, that can lead to damage over time. And so you're going to find there's kind of an imbalance here for these patients between both aggressive and sort of defensive factors, as we're going to see. So things that can lead to this include things like relaxations of the lower esophageal sphincter. So if you don't have a good seal on that lower esophageal sphincter, that can lead to retrograde movement there. If you have transient increases in intra-abdominal pressure, so someone bends over or squats down too quickly, you can have reflux. Especially like in little kids, you can see anatomic factors. This is where I have a lot of surgeries that need to be done to help prevent this. Gastric emptying issues, like diabetic patients can develop gastroparesis. And there's even the composition of the refluxate. If there's a lot of acid there, if it's very acidic, again, it can lead to more irritation. So when we're producing stomach acid, what's kind of happening here? And so you can imagine these are some of the parietal cells that you find within the stomach itself. Here's a paracrine cell that will be located next to that. And what I want to focus on here are going to be the various hormonal influences on the production of stomach acid. Here you find, this is what we call the proton pump. This is what is actually sending out protons or hydrogen ions out into the stomach to cause the acidity. Because remember, acidity, the pH, is basically a measure of the concentration of hydrogen ions, right? So this is ultimately what's going to be causing the stomach acid to be flowing out into the stomach itself, this proton pump. This will be an important target in a little bit here. But what stimulates the proton pump to work? Well, a couple of different things here which we're going to look at. So one, for instance, is going to be acetylcholine coming from the vagus nerve here, right? So we're going to see that the vagus nerve will send out acetylcholine that will be affecting muscarinic receptors. Muscarinic receptors will cause activation here, both by causing direct stimulation and also by causing the paracrine cells to release gastrin. Gastrin is another important hormone that will affect increased production of stomach acid. Okay. Not only that, but you also have histamine working here on the H2 receptors. Okay. So we have acetylcholine, muscarinic receptors. We have H2 receptors. We're going to find that gastrin is also going to be an important stimulator of the proton pump itself. Okay. So you can start to see where some drug targets are already happening here, already developing here. Now, one thing you'll notice to inhibit this process is going to be prostaglandin, so PGE2. This will be an important step here, and where we're going to find that our NSAIDs are going to be important for causing some deleterious effects here on the stomach in just a little bit. We also have some epithelial cells, and so this is important for protecting the stomach from basically digesting itself. And so you see here the prostaglandins and acetylcholine acting on the muscarinic receptors causes stimulation of production of mucus, which I always have this, I always meant to go back and respell this, but I always forget about it. Be mucus. Spelled that way, how about that? And then bicarb, right? So you're sending out mucus, you're sending out bicarb, and this helps to neutralize the stomach acid right at the epithelial layer, so that way again it protects the stomach, prevents it from digesting itself basically. And what you can notice here, the gastric lumen will have a pH of about 2, whereas the mucus layer should be around a pH of 7. So pretty well neutralized because of that. So a lot of factors can affect GERD. So certainly some physical issues, some obesity can certainly affect this, putting more pressure on the abdominal cavity. Pregnancy is a big one, recumbency, all kinds of things there. But from a more pharmacologic aspect, there's certainly plenty of drugs can do this, like alcohol use, certain medications that can either stimulate acid production or they decrease the ability to neutralize that acid. We'll get into some of those in a little bit later on, but some of these are reversible, some of these may not be reversible. In the case, some may take 9 months to reverse, as you may find. Actually, it's more like 10 months. But it's important to focus on medications and foods and things like that we can avoid the maybe worsening symptoms for these patients here. So certainly a lot of foods like spicy foods, tomato products and chocolate and all kinds of things like that can exacerbate it. But from a medication standpoint, some of these will make kind of a sense. So things like anything kind of slowing down the sort of the transit of things through the GI tract can certainly lead to backup, which can lead to reflux. So things like narcotics, like your opioids, things like calcium channel blockers, which are all both known for causing constipation, and slow down that peristalsis, will cause backup and can cause reflux. So that's one way you can see that. Anticholinergics for sure, because again, that slows down the GI tract. But we'll get into some other drugs later on. So things like bisphosphonates, which are used for osteoporosis. We'll talk about that next semester. But that actually can get caught in the esophagus itself and cause damage and cause irritation. And then we'll talk about the aspirin and NSAIDs a little bit later on. This is going to be an important one because we see that normally prostaglandins protect the stomach. But what happens if you get rid of the prostaglandins? We're going to find out in just a little bit, and that's going to be sort of caused most frequently by aspirin and NSAIDs. So our goals for patients with GERD are going to be to try to alleviate their symptoms, or at least eliminate them if we can, try to prevent the number and duration of episodes that they experience, and if we have any sort of injured mucosa, try to heal that. We'll see how we can try to promote that. And then prevent complications like secondary esophageal cancers, prevent peptic ulcer disease, all kinds of things like that. So certainly it's important to consider the non-pharmacologic measures first, because if you can do the simple things and not add new drugs to the patient's regimen, that is always going to be beneficial. So lifestyle modifications or trying to fix their behavioral sort of issues that may be leading to this. And we'll talk about pharmacologic interventions. There may be some cases where you can do surgical intervention. I will not be getting into that because, again, that resides outside of my realm of expertise. As I mentioned, with lifestyle modifications, weight loss, elevating the head of the bed to avoid that recumbency, fixing their diet, smoking cessation, all that good stuff. All the good things in life, tell them to stop doing it. If you get any sort of enjoyment out of the food you eat, it's probably bad for you. Just go ahead and stop it. It's not good for you. Just kidding. That's probably what it sounds like to the patients, though, in a lot of cases there. But We're going to find some ways we can try to deal with that. And again, if you can try to switch out medications, it could be beneficial, but you may not have a lot of leeway in that standpoint there. So let's look at the pharmacologic options we have to treat GERD. So we're going to go through these different categories here individually, so you can kind of refer back to this to get the whole list here. So the ways that we can try to inhibit acid, or basically there's 3 ways we can deal with GERD. We can try to neutralize the acid that's there. We can try to reduce the amount of gastric acid that's being secreted, or we can try to enhance our gastric mucus defense. Okay, so sort of 3 different ways. We'll see where our drugs work specifically on one of these pathways. So starting out, let's talk about ways we can neutralize the excess acid. And so this is where our antacids come into play here. They basically work to directly neutralize acid in the stomach. Okay, so you'll find there's a couple different preparations we'll talk about. Some of them have different neutralizing capacities, some have different palatability. Obviously, if a patient does not find a drug very palatable, they are less likely to take it. So that certainly is something to consider there. And so you can see kind of what these drugs are doing specifically. So the 4 that we talk about most commonly is going to be sodium bicarb. We'll have calcium carbonate. We have aluminum hydroxide and then magnesium hydroxide. And so if you were to combine these with HCl, you can see kind of what happens. So you form basically the salt form, so sodium chloride, calcium chloride, etc. And then you get water formed, and then you get CO2 formed here as well. So that's a typical neutralizing sort of reaction that happens there. If you can kind of intuit, you can already see some side effects that may develop from production of some of the CO2, as you might imagine, just a little bit. Let's get into the individual ones here. So first off, we have baking soda. You can just eat baking soda, and that would actually end up fixing some GERD symptoms there. Pretty quick way to neutralize acid, but we're going to see that sodium is going to be a bit of a problem because you're going to absorb a lot of that sodium, and that can end up producing a lot of fluid retention. So this is bad for patients who have like high blood pressure, if they have CHF, things like that, who are normally trying to limit their salt intake. This is going to be a direct counter to that, unfortunately. And again, this does produce gas. You do worry about things like eructation, right? A lot of burping and belching that go along with the use of or antacids, because it makes sense because you're neutralizing acid to produce CO2. That CO2's got to go somewhere, right? Now, the problem with all these antacids, though, is that they are good for neutralizing the acid that's there, but once the stomach detects that the pH is out of whack, that it's above 2, it's going to say, wait a second, we need to produce more stomach acid. So you kind of shoot yourself in the foot a little bit because you end up increasing gastrin release, which tries to produce more acid. And so then by that point, if your sodium bicarb is all neutralized, is all done, then you're going to come back and have the same symptoms again. So these are kind of the wimpiest out of the bunch in terms of treating GERD symptoms, but may be useful for more situational episodic sort of GERD symptoms, things like that. So if they know that they go out and they eat spicy curry or Mexican food or something like that, they're going to get GERD symptoms, this is okay. You can use it for those episodic sort of things like that. If it's more of a chronic issue, antacids really are not going to be able to cut it, unfortunately. Next up, we have calcium carbonate, or Tums. Probably everyone on earth has taken Tums at some point. It's decent for elderly patients because they probably need calcium anyway because of osteoporosis and whatnot. You will absorb some of that calcium, though. So again, you can find for patients that can lead to things like kidney stones. So you do want to be cautious there if they have that history there. And again, I talked about that rebound acid secretion, just like what we saw with sodium bicarb last slide with the gastrin being released there. Now, calcium, it's important to note here that calcium is a frequent cause for constipation. So be aware of this, because if they're on a bunch of other medications that also cause constipation, this is just going to worsen that. So you do want to be cognizant of that and make sure that you are avoiding things that are going to exacerbate whatever problems they might be having right now. So if they're having diarrhea, then antacids may not be a bad problem, right? Or having calcium carbonate on board may not be a bad issue, because it can actually maybe slow things down a little bit from that standpoint. Next, we have aluminum hydroxide. This actually is, we're going to talk about this again when we get into the nephro section, because this is actually pretty good for decreasing phosphate absorption, which is a big problem for patients with chronic kidney disease. But this can actually decrease phosphate absorption itself for even healthy patients. So hypophosphatemia could be a potential side effect there. Aluminum hydroxide is actually kind of good because it has a little bit of a cytoprotective effect. It kind of forms like a gel almost at the cell surface, so that can actually help protect the stomach a little bit from its own acid. This is another one that causes constipation, and this is going to be one that chelates other drugs. So especially calcium, you can see a little bit of chelation with things like fluoroquinolones and whatnot. This is another one because this aluminum combined to a lot of different drugs. You want to be careful and separate these out. So definitely be cautious there. And then these would be contraindicated in patients with appendicitis. It tends to make that worse. And then finally, we have magnesium hydroxide or milk of magnesia. This is going to be one where if you see it used by itself, it is frequently used to treat constipation because this causes pretty significant diarrhea. I don't know if any of you have ever experienced this, but we call mag hydroxide, we call it the green rocket. It actually comes in a green bottle when it's by itself. It kind of looks like almost like a soda bottle, and it's carbonated. That kind of help out with the palatability for the patient, and it is very good at causing patients. We call it the green rocket because patients will take it and they run like a rocket to the bathroom because it's pretty significant. It causes a huge osmotic load in the GI tract that causes them to need to defecate quite quickly. So good from that standpoint. So frequently you won't find aluminum hydroxide or magnesium hydroxide by themselves. Frequently they're going to be combined. I'll show you what that looks like in just a moment there. But yeah, so this one causes diarrhea. This one would be contraindicated in renal failure because of the magnesium load. It would lead to hypermagnesemia. And obviously, if they have an intestinal obstruction, you don't want to cause significant peristalsis to occur because that can lead to some issues from that standpoint. So that would be another contraindication. So as I mentioned, we frequently will combine magnesium hydroxide and aluminum hydroxide together, and this is where you get your Myolantas and Malox and things like that. And so by using the two together, it helps to counteract the GI motility. So whereas the aluminum would cause constipation, the magnesium causes diarrhea. You add the two together, and they balance themselves out a little bit. I don't know if you guys watched The Simpsons ever, but there's an episode where Homer gets a crab, or gets a lobster, and he's trying to keep it at home in an aquarium. And so he puts it into a thing of fresh water, and of course the thing flips over and dies. And so then he adds a bunch of salt to it, and then the thing sinks to the bottom, and it's too much salt, so he has to kind of balance out the salt in the water to make sure that it's floating there right in the middle. Kind of like that. So they balance each other out a little bit. You can look up a video of that. It's pretty funny. We typically will see liquid preparations of things like Malox and Myelanta being used here because it has a better coating effect of the stomach, and that can help to with healing of things like peptic ulcers and things like that. So the thing with the antacids you want to be careful of is the fact that, a lot of these are over the counter. So patients are self-treating themselves. You get a little bit of GERD symptoms. You go to the store, you pick up some Malox or something, you take that yourself. If they have something more serious going on and they're self-medicating themselves for a while, they may not have the impetus to go see a provider to get it checked out. And so you can kind of mask worsening disease while they're self-treating. So that's why it's really important to counsel patients, hey, don't take this for more than like 2 weeks. If you're still having symptoms by then, come on in, get checked out. We'll see what's going on here, okay? This class here tends to be safest for pregnancy because there's very little, systemic effects we worry about this. And again, they're all electrolytes, so we're not really too worried from that standpoint, except for maybe the aluminum. But one thing you do want to be cautious of is the sodium bicarb, because that sodium can lead to worsened hypertension, preeclampsia for those pregnant patients. So that would be one concern. And then certainly a lot of drug interactions due to chelation. So this would be something you want to avoid giving at the same time as like tetracyclines, iron products, fluoroquinolones, all of that, because they will bind up together and then they will be basically neutralized. So typically what I'd tell you to do is to give the interacting drugs like a tetracycline an hour before the antacid or 3 to 4 hours afterwards, and that will prevent the interaction from occurring. So antacids, kind of the benefits here is that they have pretty rapid relief of symptoms. So if you're having, GERD symptoms right now, they'll kick in, they'll work pretty quickly. And they're relatively inexpensive as compared to some other agents we'll talk about. And most of them are available over the counter. So good for breakthrough symptoms, not good for chronic issues there. Some disadvantages, they're not really great for healing so much as you're going to see with other agents we'll talk about. And they're going to require pretty frequent dosing if they have more kind of consistent symptoms throughout the day. And as I mentioned, kind of keep note of which ones cause constipation or diarrhea, because that could be an issue depending on what your patient's already experiencing. And then we mentioned the potential for drug interaction. So overall, decent set of drugs, but not really going to be the most effective ones that we have available to us, as we'll see. So up next, we have our, we talked about neutralizing the acid. What could we do potentially to either reduce gastric acid secretion or actually protect the mucosa? So let's look at how we can reduce gastric acid secretion here. A couple ways we can do this just by looking at this picture. We could directly inhibit the proton pump. So that's where we get our proton pump inhibitors. We'll talk about a little bit later on. We could do things like preventing the activity of acetylcholine. Maybe one way to do it. We could block histamine. We could maybe try to block gastrin, or we could try to give more prostaglandins in order to inhibit production here. We're going to see that some of these are a little bit more common than others as we'll get into. So first ones we want to talk about is going to be our H2 receptor antagonist. This is probably the oldest bunch out of the group here. It's been used kind of consistently for many decades. And basically by blocking the histamine receptors here, the H2 receptors are going to be able to decrease basically around the clock production of stomach acid here. So overall volume and the hydrogen ion concentration is going to go down, such that pH of the stomach will increase from 2 to something closer to neutral. It also can reduce pepsin, activity of pepsin as well. So that way it's not, that can lead to some digestive issues, but for the most part, it's decreasing acid production. So, and this is actually looking at the 3 drugs we have in this category. We used to have 4, and it's kind of wild to think about that, something we've been using for decades and decades got removed, but ranitidine or Zantac is no longer on the market. It actually got removed this year. There were some concerns that the drug itself, especially if kept at high temperatures, like say in Florida, that it could actually break down into a cancer-causing compound, a carcinogenic compound. So they actually ended up taking it off the market completely. So the 3 that we have here are going to be cimetidine or Tagamet, famotidine or Pepcid, and then nizatidine. And actually, out of the 3 we have left over here, one of them I will tell you to never, ever, ever recommend ever. And I'll tell you why in just a little bit. So these drugs here are going to be pretty well absorbed from the GI tract. They do undergo renal elimination, so you do want to watch for renal function and make sure you adjust for that. So if they have significant renal dysfunction, maybe you have to give them the drug less often, or maybe a lower dose, as the case may be. In terms of side effects here, these things are really rare. These drugs are pretty minimal in terms of side effects, pretty well tolerated by most patients. But in some cases there, you could see some CNS confusion, maybe thrombocytopenia, but I've never seen a single patient have any of these. So I probably would not be too concerned about them. These are just kind of reported, but exceedingly rare. So you'll find this is effective in a good chunk of patients you're going to run into, certainly more effective than antacids. And based on the fact that they're relatively cheap and available over the counter, they do get used quite often. So again, this is another one that patients will sort of self-treat with by buying it over the counter there. Oops. So we'll find that oftentimes, when we're selecting agents, any of them can be equally effective. Obviously, at least with these 3 that we have available to us, most of the time it's just based on cost. Whatever's cheapest for your patient tends to be best. They tend to be more expensive than your antacids, and they're pretty good for pregnancy. Category B, we'll talk about pregnancy categories next semester, but B is generally pretty safe for pregnant patients. A and B is very safe. And now when you're looking at over-the-counter dosing, they typically only recommend it for about 14 days, and because again, they want to make sure that patients are not going to be self-medicating and trying to mask symptoms of more serious things going on, like peptic ulcers and things like that. And of course, make sure you're modifying a dose for patients with renal dysfunction, if they're elderly, things like that you want to be careful of. Now, some patients, the way you can use these is that with antacids, you would just use them as soon as you have GERD symptoms happen, right? So you don't necessarily take them prophylactically. With H2 blockers, you could use them prophylactically. So you could say, okay, well, if I know I'm going to go to my favorite restaurant and I always get GERD afterwards, you can go ahead and pre-treat with an H2 antagonist. Or you can just use it daily. Some people just use that every day in order to prevent symptoms if they're more consistent, more chronic, okay? Now, one thing I will tell you is to never ever recommend cimetidine because it is a potent CYP3A4 inhibitor, right? And again, this is something I would recommend to patients if they might be likely to take a H2 blocker. Tell them if they're going to buy this stuff over the counter not to buy cimetidine because they can find all kinds of drug interactions. I've had plenty of people who have had a significant drug adverse effects related to this inhibition, so be very cautious with that. They're taking statins, if they're on, non-DHP, if they're on taking warfarin, if they're all kinds of things can interact here. So you really want to make sure that they're avoiding cimetidine at all costs. You don't have any of that problem with something like famotidine or nizatidine. So probably nowadays Pepcid is probably the most common one we use. All right. So up next there are going to be our proton pump inhibitors. And so instead of trying to affect any of these other sort of upstream receptors here, let's just directly affect the actual proton pump itself. And so these are sort of the newer class of drugs here, but they tend to be the most potent out of the bunch. And so you can actually find that they form an irreversible bond here. So in order to produce new stomach acid, your stomach needs to produce, or your cells need to produce new proton pumps. So very, very effective. Can reduce stomach acid production quite significantly. And even, with the antacids, you saw that could cause rebound gastrin stimulation of stomach acid production. It doesn't matter if you even have that here because the pump is still inhibited. So very, very potent. Several drugs in this category. Here we have omeprazole, and it's an enantiomer esomeprazole. We have lansoprazole, pantoprazole, and then rabeprazole. So those are the 5 main ones you're going to run into there. And so in terms of adverse effects, they're pretty minimal for most patients here. However, some things you can see, this is kind of more important from a more chronic standpoint here, is that you will definitely find that you'll have elevated stomach pH, right? Which makes sense because you're not producing as much stomach acid. For some patients, you can actually produce bacterial infections. So who does that become a concern in? The biggest thing I think about it with is, say you have a patient who is in the ICU, okay? You have someone who's like sepsis, they're intubated, they're in the ICU for a long period of time, say for a couple of weeks. What happens in like critically ill patients is they get very physiologically stressed out, right? And so what do you produce when you're stressed, which you guys probably produce as well, is cortisol, right? Cortisol is a corticosteroid. Cortisol is going to decrease prostaglandin production. They're anti-inflammatory, right? What you find for these patients is that they have less prostaglandins being produced, and they don't have the ability to produce that protective barrier around the stomach as well, right? So patients who are chronically or critically stressed will develop peptic ulcers because they don't produce those prostaglandins anymore. So I said, okay, well, let's prevent these stress-induced ulcers. Let's go ahead and give them a proton pump inhibitor. A proton pump inhibitor will prevent the stomach from being able to digest itself, basically. So that's all well and good. But normally, like with the pH of 2, the stomach is very resistant to infection because really no bacteria can survive in that environment besides like H. pylori or something. So what happens is that when you have the pH being raised up for the course of several weeks in these like critically ill patients, they will then start to cause bacteria to grow. Bacteria will grow, and then they can then travel around. They can go up through the esophagus and then get down at the respiratory tract. So that is one way in which you can get things like ventilator-associated pneumonias potentially as a result of that. So again, it's a double-edged sword a little bit. That's why good oral hygiene is really important for those patients, but something to consider there. So bacterial infections are not common, but can happen, especially in those more at-risk sort of patients there. Yeah. Now, typically, we're going to give these prior to meals about 30 minutes or so because the pumps need to be active for the drugs to affect them. And so when do you produce the most stomach acid? Well, probably during mealtime when you're digesting food. So that makes sense with that. And we tell them to not crush or chew. This is critically important as well because the drugs themselves, if you ever look at one of these capsules, they will include a bunch of tiny, tiny little beads inside. You're like, why do they have those little beads in there? Those beads are protected by an acid stable coating. And so basically what happens is that the drug themselves would get destroyed in a very acidic environment. So by taking the drug and having this coating, it will then go through the stomach, travel, the coating will stay intact because it's stable at acidic pHs. And then once it gets down to the small intestine, where the pH is now raised up because your pancreas is spitting out bicarb, you will then cause that outer coating to melt away, and then the drug is free. Okay, that drug can then be absorbed and cause this inhibition of the proton pumps. So if you crush or chew those beforehand, then that will then inhibit, that will then break down that coating, and the drug will get destroyed in the GI tract. So not great. In terms of efficacy, you're going to find your proton pump inhibitors are more effective than your H2 blockers in terms of healing. So especially if they have like significant esophagitis or peptic ulcers or something like that, PPIs are going to be preferred. They tend to be a little bit more expensive though. In terms of adverse effects, again, these are very well tolerated for the most part. Most of the stuff is just kind of reported, just like any drug you would see. I'm not too concerned from that standpoint. The infections, though, are something I would consider more so in critically ill patients. In terms of drug interactions, you can see some issues. These are metabolized at least partially through CYP3A4, so things like ketoconazole, itraconazole, some antifungals can affect that. And your iron salts can bind up to it as well, so some things to be watchful for. One other thing here we could do is try to prevent the activity of gastrin. And so we have a drug called octreotide, which is actually a somatostatin analog. So it's a normal hormone that you normally produce, but it actually blocks gastrin release. And so this can be good for some patients with things like gastrinomas or something called Zollinger-Ellison syndrome, which is a hypersecretory sort of condition there. And so this is used occasionally. Some cases will actually use it for severe diarrhea. It can actually help to decrease peristalsis as well. This is going to be a parenteral product only, meaning this is something you would get in the hospital, not something you would see patients using at home by any means. I like to use this drug for patients who have a certain type of overdose called sulfonylurea. The drug we'll talk about when we get into diabetes later on next semester, but this actually helps to treat those patients to prevent them from releasing a ton of insulin and causing hypoglycemia. You guys don't need to know that, but this is where I most commonly use octreotide. So we talked about ways to neutralize the excess acid. We talked about decreasing production. Now let's get into the mucosal protecting agents. This is where we can get things that will help to coat the stomach and prevent the acid itself from trying to degrade it, right? And so things like colloidal bismuth, so Pepto-Bismol. I'm sure most people probably heard or seen or have taken this at some point in their life, that kind of chalky pink liquid you might be taking when you have GI effects. Again, it's helpful because it helps coat the stomach and will help to sort of enhance the cytoprotective effects your stomach would normally have there. Not only that, but it can also inhibit pepsin activity. So again, part of that digestive sort of process there. One thing to note with Pepto-Bismol is it can cause black discoloration of the stool. That is important to know because if patients have black stool, they may think that they're having an upper GI bleed, which is maybe being used to prevent in the first place, right, by protecting the stomach. So that is a concern there. Just let them know this is normal. It's not a big deal if it does happen. And this does contain salicylate, so I would definitely avoid this in kids, especially if they are post-viral. I would not want to give that because we're about Ray's syndrome with that. Another one called Carafate or sucralfate. This is actually going to be a non-absorbable aluminum salt that once it combines with acid, it forms this nice paste that will then kind of coat the stomach there. This is typically used for very mild cases of GERD. If you didn't want to use like a proton pump inhibitor, H2 blocker, or something like that. I see this used occasionally, but it's pretty wimpy in terms of efficacy. But maybe like a useful add-on. If maybe like an H2 blocker wasn't doing it by itself, you can maybe add on Carafate or something like that. That could be reasonable. And then we have misoprostol. So this is actually going to be a prostaglandin analog. This is called Cytotec. So instead of, basically instead of trying to decrease acid production, we can give something that stimulates production of that protective barrier here. And this is where we have misoprostol. So this is really good for patients who maybe have ulcers that are due to NSAIDs, because we know NSAIDs decrease prostaglandin production. This could directly counteract that. So that could be really handy from that standpoint. Now, this is actually going to be contraindicated in pregnancy because once we get into OB-GYN next semester, we'll actually find that prostaglandins can stimulate contractions of the uterus. And actually, this can be a means of chemical abortion. And so you would not want to give this to a pregnant patient who wanted to keep that baby because that would actually cause a premature contractions in labor, and that would not be great from that standpoint. So, but this has been used occasionally in the past in order to induce an abortion from a chemical standpoint. So that's a use, but more commonly you're going to see this being used from a GI standpoint there. But interestingly enough, you will find certain institutions may carry certain drugs based off of their religious background. So for instance, I was an intern when I was in school. I interned at St. Vincent's Hospital up in Jacksonville, and that was a heavily Catholic institution, and they didn't even carry this drug in stock because they did not want it even possible for someone to take this and potentially cause an abortion to occur. So I always thought that was kind of interesting when you see sort of that intersection between religious beliefs and use of medications. There are a handful of those situations that come up, and this was one example that actually where they said, we just don't need to carry the drug. And oftentimes it's not usually a problem. We have lots of other means of treating these GI effects, but it's at least worth mentioning here. And so if you were to kind of compare the different agents you can see here, certainly PPIs tend to be the most costly, but they also tend to be the most effective, especially if you have mucosal damage, esophageal damage that needs to be treated. That all can be very beneficial to help in order to help with that healing. H2 blockers probably second to that, followed by antacids and then Carafate. But if you're having patients with just like episodic symptoms whenever they eat certain types of foods, antacids are fine. It just depends on the patient there. And so in terms of GERD treatment, you kind of want to go from a phase standpoint. So if it's not episodic, it's more of a chronic thing there, you may find patients will go through sort of peaks and valleys in terms of effects. So you may need to kind of up your therapy a little bit and then scale it back down depending on kind of what's going on with the patient. So you may need to go to higher grade PPI therapy for a while and then back it back down as symptoms kind of get under control there. And obviously, always, again, I apologize, my 2-year-old is knocking on the door. She might be entering. She's figuring out how to open the doors now. You may find that lifestyle changes are always going to be recommended here for the most part. Always introduce those changes for your patients, whether they follow them or not. And you'll find for kind of the most intermittent forms, antacids, over-the-counter H2 blockers, those are all reasonable. As you get more significant, where you're having more damage being done, this is where you're going to get into higher PPI therapy, high-dose H2 blockers, things like that. If they're still refractory, this is where you get into more interventional therapies, okay? So if I had a test question that said, okay, a patient is currently taking over-the-counter famotidine, but they're still having symptoms, what could you then change them to? And you probably want to say PPI. Something like a H2 blocker would not be reasonable, right? Something like an antacid would not be reasonable because if they're on a H2 blocker and that's not working, then an antacid is not really going to do much additional benefit. That makes sense. And then for most patients, you're going to find that they will have some degree of relapse if it's more of a chronic thing for them. And so for them, they may need, chronic therapy. It just really depends. For more mild disease and get away with H2 blockers is usually a little bit more economical. For more moderate severe disease, proton pump inhibitors are going to be your go-to. So with that, I think I'm going to go ahead and cut it off here just due to the fact that we're kind of close to time. And I want to leave some time. So next week we will not meet because that's Black Friday. So hopefully you guys if you're going out shopping, do it in a safe, socially distant manner or buy online. And then the following week will be our last session. We're going to finish this up and then we will have time for review. So whatever questions you have, please bring them to the group so that way we can all talk about them and get you guys set up for the test there. So someone did have a question. Let me see here. Someone said, do side effects vary between agents in the same drug class? For example, if a patient has constipation from taking omeprazole and then they try a different PPI, presumably they get the same thing. It depends on the patient. You may find that they will respond better to one than the other. Keep in mind that not all dosing is exactly the same between the drugs. So maybe they switch over to a different drug, but it's a relatively smaller dose. In terms of potency, and maybe they get no effects from that. Maybe they get no constipation. So they can try it. They don't like omeprazole, they can try taking lansoprazole and see how that works for them, and just see. All right. Any other questions or anything before I let you guys go? If not, have a great week. Have a happy Thanksgiving, however you celebrate it, and I will see you in 2 weeks. Someone said, is it safe to assume all chemo causes nausea, vomiting? Yes, but just like I said, it's a risk for any chemo drug, but if you looked at that immunogenicity list there, you can see some are more so than others, but it's reasonable to say, yeah, all of them can cause it for sure. All right, well, thanks a lot, guys. I will see you next time.